Hi, this is Dr. Nishad. I'm a radiologist. Today, I would like to talk about slipped capital femoral epiphysis. So, first we describe the condition. What is it? What is meant by slipped capital femoral epiphysis? So, it is the posterior and medial displacement of the femoral epiphysis with respect to the metaphysis. The femoral epiphysis will be still located within the acetabulum, but there will be relative slippage of the epiphysis with respect to the metaphysis. And what is more important, the direction of the slippage, that is really important. And always remember this, it will be displaced posteriorly and medially. And the metaphysis, if you talk about the metaphysis, the direction of the slippage will be anteriorly and a bit superiorly. Okay, now give me a second. So, what is the incidence of this condition? It is around approximately 10 out of 10,000 people are affected, and it affects most commonly the teenagers. That means the age group is approximately around 14, 15, and it classically affects the males. Females are also affected, but the males are more commonly affected. The patients with overweight, again, the overweight is one of the important risk factor. Ethnicity is also important, like African American, Hispanic, and Pacific Islander. These are some of the ethnic groups who are selectively involved by this condition. And yes, there are certain endocrine disorders you need to think of, like hypothyroidism, hyperparathyroidism, and growth hormone deficiency. These are few of the endocrine disorders which can result in SEFE or slipped capital femoral epiphysis. Now, the ideal age, I did not mention that the classical age group which are affected are 10 to 17 years if it's a boy, and if it's a girl, approximately 8 to 15 years. That's the most common age group affected. And how the patient is going to present to you? The patient is going to present with hip joint pain, and the pain eventually it can lead to a limp, and sometimes if it is prolonged it can even lead to leg length discrepancy. And 20 percentage of the cases are bilateral. That means 80 percentage of the cases are, in other words, unilateral, and 20 to 40 percentage of the cases develop later. That means it may start with the disease on one side, and after, in 20 to 40 percentage of the cases, the opposite hip joint is also involved. Now, depending upon the duration, we can classify the slipped capital femoral epiphysis into three types. The most common one is chronic. That means the duration is more than 3 weeks. Acute means the duration is less than 3 weeks. Now, the patient must be having this condition for long, and suddenly the patient is presenting to you with severe hip joint pain and restricted movements, and then that becomes the acute on chronic type. So what is it? This is the posterior and medial displacement of epiphysis. So here, this is the epiphysis and this is the metaphysis. The arrow, follow the arrow. There will be slippage of the epiphysis with respect to the metaphysis, and the direction is very important. It will be posterior and medial, as you can see in this figure. In other words, the metaphysis, if you are talking about the metaphysis, there will be slippage of the metaphysis which will be superior and anterior. So learn at least one. The direction of displacement of epiphysis, it is posterior and medial. And also remember this, the epiphysis is still located within the acetabulum. And pathologically, it is considered as a type 1 epiphyseal injury, a type 1 Salter-Harris growth plate injury. And what could be the cause for this type of injury? It might be repeated trauma on a background of mechanical and probably hormonal predisposing factors. So, the conditions like obesity or growth spurt, the age group we mentioned, that means the adolescent age group, be it a male or a female, that is the time when there is maximum growth spurt happening. So during that time, the physeal plate, so this is approximately the location of the physeal or the epiphyseal plate. That plate undergoes widening and the growth will be more pronounced during the growth spurt phase. So the axis of the physis becomes more oblique than horizontal, and when it becomes oblique, the shear forces or the mechanical forces are going to act across the growth plate. So the oblique direction, it favors an increased risk of fracture or increased risk of slippage. The endocrine disorders that predispose to this condition: hypothyroidism, hypopituitarism, obesity, renal osteodystrophy, and hyperparathyroidism. Now, how will you diagnose a case of slipped capital femoral epiphysis? The first choice of investigation to diagnose this condition is X-ray. And what are the views taken? There are two views, AP view and frog leg lateral view. Ideally, frog leg lateral view is the best projection rather than the AP, and the reason is that the direction of the slippage of epiphysis is posterior and medial. So on AP view, the posterior displacement is less appreciated, and that is why we go for frog leg lateral view. Now, a few points about the frog leg view. The patient should be supine. There should not be any rotation of the pelvis. The affected limb should be flexed at the knee, but not too much, only up to 30 or 40 degree, and the hip, that should be abducted approximately 45 degree. So that is the typical position in the frog leg lateral view. Now, in the first figure, you see the relation of the epiphysis with respect to the acetabulum. Here, it is N located, that means it is located within the acetabulum. Now, look at the relation of the epiphysis with respect to the metaphysis. On both sides, it is normal, and this view is the frog leg lateral view. Now, in this figure, the right sided figure, you can see that there is slippage of the epiphysis medially, right? You can compare that with the opposite side, there is no slippage. So there is slipped capital femoral epiphysis on the left side. So what are the X-ray features that help you in the diagnosis of slipped capital femoral epiphysis? One, the most classical is the slippage itself. But sometimes in the early stages, you cannot see slippage, but there can be some other signs that can help you consider the possibility of SCFE. So the slippage of the epiphysis may not be seen in the early phases. In the earliest stage, you can see they sometimes there can be an irregularity of the growth plate here, or sometimes the widening of the growth plate can be seen. The metaphysis can appear less dense or demineralized, and all these changes are later followed by the acute slip, which is posteromedial displacement, as we discussed before. Now, if the slippage has become chronic, then what will happen? The physis will become more sclerotic, and the metaphysis it becomes more widened, which is called as the coxa magna. There is one more sign I would like to explain right now, but before that, we will just summarize the findings. So, in the earliest stages, the epiphysis it can show reduced height. The physis or the physeal plate can appear widened and irregular, which is followed by a slippage of the epiphysis, which is posteromedial. And in chronic phases, the metaphysis it can become more widened and sclerotic, which is called as the coxa magna. Now we go to the next slide. It's not working, I'm sorry. Yeah. So what is meant by clean line? So we will explain that. It's important. So clean line means we draw a straight line along the lateral cortex of the femoral neck over here. And if you draw a straight line like this, you can see the line is cutting through only a part of the epiphysis. It goes like this. So this line is called as the clean line. And what is the significance of this line? If there is a slippage of the epiphysis, as in this case, you can see if you draw a line along the femoral neck, the lateral femoral neck, it is not cutting the epiphysis because the epiphysis it has displaced medially. So clean line can be used for assessing the medial displacement of the femoral epiphysis. Now, what are the types of displacement? There is something called as the linear displacement and there is angular displacement. If it is linear displacement, there is a method to assess how much is the epiphyseal slippage with respect to the width of the metaphysis on frog leg view. So again we go back to the picture. So if it's Wilson's method, what we do is that we assess the severity of the epiphysis slippage with respect to the width of the metaphysis. So this is the width of the metaphysis and we assess how much of the epiphysis is slipped with respect to the width. Okay. And second is angular displacement. To assess the angular displacement, we use a method called Southwick method. And what we do is that there is something called as epiphyseal shaft angle. We measure the epiphyseal shaft angle. We will see how we measure that. And after measuring this, we compare the shaft angle, epiphyseal shaft angle, with the opposite normal side. Okay, let's see how we measure that. So look at the second picture, how we measure the epiphyseal shaft angle. First you draw a tangent line. This dotted line represents the tangent. I am going to draw between the epiphyseal borders, the anterior and the posterior borders of the epiphysis. Here there is one point and there is another point. We connect these 2 points, we get the epiphyseal tangent line. Now we draw a perpendicular to that tangent line. Now the third line is along the long axis of the femur. You can see we draw a line along the long axis of the femur like this. The angle between the perpendicular to the epiphyseal line and the long axis of the femur, that angle is the epiphyseal shaft angle. We measure the angle and we compare with that of the opposite side. This gives a measure of how much angular displacement is there. So we go back to the slide. I'm sorry, this is hanging too much. Yeah. So we measure the epiphyseal shaft angle, and if the difference from the normal side, if it is less than 12 degree, then that difference is normal. If it is mild, the difference is less than 30 degree. If it's moderate, then it's between 30 and 50 degrees, and if it's severe, there's a more than 50-degree difference. Okay, so at least remember this clean line. We draw a line along the lateral femoral neck. We see if it is cutting a part of the epiphysis. If it is not cutting the epiphysis, then it's likely to be displaced medially. There are two types of displacement. Linear displacement, we measure the medial displacement of the epiphysis with respect to the metaphyseal width on frog leg view. Angular displacement is measured by the Southwick method, by which we measure the epiphyseal shaft angle and we compare with that of the opposite normal side. And if there is less than 12 degree difference, it is normal. Now, most of the cases, if it's typical, it can be diagnosed by X-rays, but sometimes there is a role of CT. If the case is really very severe and the patient cannot be, if the patient cannot move his hip, if there is limited range of motion, then there is a role of CT there. Or X-ray, sometimes it gives equivocal findings. Where there is a diagnostic confusion, you can employ the use of CT and MRI. And sometimes the if there is any other causes of pain, like since we described in the beginning that a slipped capital femoral epiphysis comes with the symptom of hip joint pain, we also think of other possibilities. So osteoid osteoma or septic arthritis can present with the same symptoms, which can be diagnosed more easily with the cross-sectional imaging. Now, if the contralateral side is involved, it's a very important thing to consider. Usually, the patient present with a unilateral involvement, and you diagnose the case, and you may go for the treatment. You may stabilize the hip on that particular side, but later you come to know that the other side also gets involved because you operated on one side, you stabilize that particular joint, and that can cause a mechanical instability on the opposite side, because the opposite side is also or was also predisposed to the same condition. So in short, you have to think of the possibility of epiphyseal slippage on the opposite side, and some orthopedicians, they go for a proactive measure in such cases, like prophylactic surgical pinning. So CT and MRI will help you to see if the contralateral side is involvement for the early treatment. Now, what is the role of MRI? MRI can give you the possibility of this condition in the pre-slip stage. That means the epiphysis has not yet slipped. How does it help? Let's see this figure. So what are the findings? You see the acetabulum, you see the epiphysis, the physeal plate, the metaphysis. Okay, so what is the finding here? You can see the joint effusion, so which can be a feature of slipped capital femoral epiphysis. It's a very non-specific finding though. Now, periepiphyseal bone marrow edema, you can see patchy bright signal there or patchy hyperintensity there, which suggests bone marrow edema. These are the two findings, and the slippage may not be seen in such cases. So, in the early stage, this might be the symptom on MRI, which is not seen on CT, which is not seen on even X rays. So, how will you treat the condition? I will be just going through that. Initially, the people used to go for conservative management. That means the limitation of activity, the casting. These were, used in the previous days, but it's not recommended these days. They go for surgical pinning. Now, the treatment of the contralateral hip is more controversial. As we have discussed before, 20 percentage cases can be bilateral. So one side, if stabilized, it can precipitate the slippage on the opposite side. So we may go for a prophylactic surgical pinning. Now, if there are significant deformities, conservative measures will not help. So the orthopedicians may go for osteotomies, and in the extreme cases, they may even go for joint replacement. What are the possible complications? If the condition is left untreated for a long term, it can lead to osteoarthritis. Avascular necrosis can happen, or chondrolysis, which is otherwise called as the acute cartilage necrosis. Eventually, the condition can lead to deformity and limb length discrepancy. Now, if there is slippage, there can be altered mechanical forces acting across the joint, which can lead to an altered contour of the metaphysis, the femoral metaphysis. So the anterior superior part of the metaphysis, it can develop a bony bump. This can result in femoroacetabular impingement. So these are the possible complications. So differential diagnosis, if it's a classical case which shows the epiphyseal, which shows the classical findings we described before, it's easy to diagnose. But sometimes in the early stages, the only symptom might be a painful hip, and on X-ray we may not see anything. So in such cases, we have to think of other differences like septic arthritis, transient synovitis, etc. Late presentation developmental dysplasia can look like slipped capital femoral epiphysis. If there is loss of epiphysis, height, and fragmentation, if it develops later, it may look like Perthes disease. So these are the possible differential diagnoses for a painful hip. Thank you.